I think talking about special issues or special populations in prison is probably one of my biggest passion points, and that'll make sense as we move through it. But essentially, when we're talking about special populations in a prison, this is anyone in or having needs other than or outside of what we would call general population. So we're talking about folks who have some pretty significant substance abuse issues, HIV or AIDS, mental illness, as well as our elderly population. So we're going to talk a little bit about each one of those, and then we're going to talk about some legal issues that surround each of these populations. So ultimately, special populations is really a status in that we're really talking about those prisoners that have a unique either physical, mental, social, or programmatic need that distinguishes them from other prisoners, and that we need to respond to that in what we might call a non-mainstream or non-traditional or innovative way. We are seeing the level and number of special population inmates growing exponentially, and these folks ultimately take a whole lot more time to work with, plus in some respects require some pretty intensive training in order to learn how to respond to their special needs. So let's first talk about substance abuse. And ultimately, we now have, at least in Minnesota, but several other states have responded with the same requirement, that we screen all offenders for substance abuse. And from that screening, we find that about 83% of offenders coming into prison need substance abuse treatment. However, based on the resources that we have, only about 13% are going to be able to go through the substance abuse programming or chemical dependency treatment program that the facility has. So we really have to prioritize. We're really only dealing with some of those who have the most persistent substance abuse issues as they come into prison, which is really kind of frustrating because we know statistically that going through chemical dependency treatment while in prison has some of the greatest impact on recidivism rates. And so that's one of the things that sometimes gets frustrating, because we know what a great impact this particular program has, yet we can only make it available to a very small percentage of our offenders. We've also seen most prisons shift their substance abuse treatment programs to that therapeutic community. Now, I've talked about this in past weeks, and again, this is basically just where they have a separate housing, and absolutely everything they do somehow relates to their programming or to the treatment program, and it's called a therapeutic community. When we look at the HIV positive or inmates who have AIDS, we see 2.5 times more individuals than the general population. And so those with an HIV or AIDS status in prison is 2.5 times greater than the outside world. Where we are challenged in dealing with this population is as an officer, and data privacy and HIPAA, you do not have the right to know. That's why we use what's known as universal precautions, in that we are trained to treat every individual as though they are HIV positive. That's why you see us gloving up before we're going to be dealing with an individual. Some of the current controversy is whether or not inmates have the right to treatment. And ultimately, what it's really decided is that, yes, they do have the right to treatment for their HIV or AIDS status. However, we know that technology and research has some really, really innovative treatment. Ultimately, those in prison are not going to have access to some of the most recent treatment options for their HIV or AIDS status. Mental illness, and I've talked a lot about this in the discussion forum. The National Institute of Corrections has identified mental illness as the single greatest issue in both jails and prisons. To work with mentally individuals costs twice what we would call normal incarceration. It costs double. And really what we're finding is that both the staff as well as the facility itself is not prepared to deal with the level of inmates or level of needs that these mentally ill individuals are presenting. And again, this population has grown exponentially. And we know, or we've been able to identify three primary reasons. The first is the closing of mental health facilities. We saw this nationwide. My state, again, Minnesota, was hit especially hard. And so these folks were deemed needing to be in a mental health facility, residential facility one day. Literally the next day, they were deemed healthy enough to be released because the facilities were closing down. Those that didn't have a strong support system, didn't have family or really secure places to go, ended up homeless, on the street, and were ultimately arrested and now are in prison. One of the other challenges or reasons we've seen this population grow is because of the lack of insurance. If you don't have insurance, you can't afford your meds. If you don't take your meds, the symptoms develop, and a lot of times that leads to criminality. We've also seen the three-strike laws, so those habitual offender statutes really impact the number of mentally ill individuals in prison. So those are the primary issues that we're seeing. I'm going to shift gears here and show you a video. It's called Trapped, and it really helps to identify some of the primary issues of dealing with the mentally ill. Now, this video should start automatically. It's about 7 minutes long, so bear with me.
Most people, most experts tell us that the money for mental health hospitals and those types of treatments in the community has dried up, and those people are coming to prison. We're the surrogate mental health hospitals now.
Even though it's not against the law for somebody to be crazy, it's against the law for us to let them hurt themselves. It's a thin line between mental health and security.
There's folks back on C Wing who are so sick and delusional and psychotic and really just in another world. It's like these are people that society has forgotten about or would like to forget about, and it's really sad.
There's not that much that an inmate watcher can do because obviously we're just inmates, but I do what I can, you know. If they want you to write their kids, write their mom, their wife, just want you to stand there and talk for a minute, you know. A lot of times they'll just want to errand run to the guards, so I'll, even though the officers get tired of hearing it, I'll come up and keep asking, you know, because it shows them that somebody's in their corner, you know.
You feeling all right today? Depressed? Yeah, it's one of those days. You not hearing the voices today? Not really? Good, good, good. How's those bullet holes? They healing up nice, or?
We really want to stabilize people and get them in the least restrictive setting as safely but expediently as possible. Many of them want to get out, but then some of them don't because they've been in society and they saw what happened there. To be so beaten down, either physically or emotionally, that it's okay for you, or you even prefer, to be locked in a room and locked in a room for 23, 24 hours a day, that is a miserable experience.
It's crazy. I've seen grown men cry for no reason. I've seen people cut and bleed so bad you couldn't even hardly recognize them. I've seen people hang themselves. When an inmate's in a psychotic episode or just being disruptive, their strength is amazing. And sometimes it takes 2 people to get their hands. Sometimes it takes 3 or 4 people to get their hands restrained. We get assaulted probably 6, 7 times a week. Sometimes we get assaulted 6, 7 times in a day.
Again, it's like I got you first time. Once you get back in the cell. Don't you play this. Don't block the doors.
They're rejects of society, and warehousing them in prison isn't the way to go. Most of them don't have life sentences. They will get out someday. So what do they do when they get out? I mean, they will be my neighbor, your neighbor, somebody else's neighbor, somebody's homeless person, somebody walking the street. If we don't care about them, if we don't want to do anything with them, who will?
No, please, no! No! No!
Charlie, hey, Charlie, calm
No! Please stop! Please stop! It doesn't matter what it is. Stop the suffering. Whatever you're doing is suffering. Whatever you're doing is suffering, Charles.
Charlie, do you hear me?
All right, so that video really demonstrates some of the biggest challenges that we have with mental illness. And again, the National Institute of Corrections has said this is the greatest issue that we have. As the video showed, we're just not prepared to deal with these folks. Prison is not an appropriate place for them, yet we don't have a whole lot of options. And again, that's one of our biggest struggles. All right, as far as older inmates go, now here again, you need to kind of take this into consideration. According to the Department of Corrections, we generally classify older inmates as anyone 50 or years or older. Of course, in the outside world, we generally look at age 62, 65, but ultimately what the prison has found is that a 50-year-old, especially if they have a significant history in the prison system, life has not been easy for them. And at 50, they are showing the physical age of someone who is 65. And so that's why we begin classifying someone as older at age 50. At the rate we are currently going, in 2025, 1 out of 4 offenders is going to be classified as an older inmate. A couple of things that we're dealing with is end of life in hospice programs. Offenders are dying in prison. They've been given a life sentence, and this creates challenges. Basically, we have geriatric units, we have nursing homes inside of prison. This is very, very expensive. About $70,000 a year is what it costs to house an elderly inmate in what would be who has some needs such as nursing home needs. Remember, the average price for general population offenders is anywhere between $25,000 and $40,000, so significantly more. Some of the issues that we have and some of the big questions that we need to ask is, why are we not releasing these folks? Now, some people say it's tit for tat. You know, if we release them, they're going to go into a nursing home. They don't have the funds. It's going to be taxpayer money regardless. However, we need to really look at is, what is the purpose of housing them? We know recidivism rates. If we just release them, they hit age 55 and we release them, statistically only 2% are going to return. They have once someone hits age 55, they have a significantly lower recidivism rates. And again, the challenge that we need separate housing units. We have several facilities that have basically changed a housing unit to resemble a nursing home because of their needs. We also have to have the question, or answer the question, of what level of medical care should be afforded to these folks. Should they be eligible for transplants? What level of treatment? Should we have a geriatric prison? Is what some states are dealing with. Regardless of the special population that we are talking about, we know that there's a lot of legal issues that surround it. Now, the Supreme Court in 1976 in Estelle versus Gamble basically established that inmates have a constitutional right to reasonable, this is right from their decision, have a constitutional right to reasonable, adequate health services for serious medical needs, but do not have unqualified access to health care. So in the last few lectures, I've talked about this principle of least eligibility, and that is the Supreme Court case language that concept came from. So yes, we have to provide, the Supreme Court says absolutely, you must provide medical care. However, all it says is reasonable and adequate. And where we're challenged is we don't know how to define that necessarily. Prisons do qualify as a public entity, and so the Americans with Disabilities Act does apply. We cannot discriminate against offenders that might have a disability that qualifies them under the Americans with Disabilities Act. And so that's why you are seeing some modifications being made to folks who are in wheelchairs or have other significant disabilities, that we have to make the modifications to comply with the requirements of the Americans with Disabilities Act. The Supreme Court has also said that offenders have a right to treatment. However, they've quantified that and saying that they have the right to treatment if what is ailing them is considered either curable or manageable through treatment, and that if the delay or denial would cause more harm. And again, this is one of the things that then comes into question, saying, what if they're due for release relatively quickly? And those are some of the things that the institution with the medical professionals need to decide. And yes, we can force an inmate to take treatment. Now, a lot of times what this is referring to is medications, that we can force an inmate to take medications if it is seen in the best interest of the inmate and to meet what we refer to as the peniological objectives. Basically, what we need to show is that by forcing them to take this this drug, we're doing it because there's a peniological objective that outweighs their right to deny it. And a lot of times this is talking about safety and security. If we have someone who is extremely violent in their behaviors and we know that there's a medication that will alleviate those symptoms and that violent behavior, the facility can force them to take that medication to meet the needs of the facility in needing to be safe and secure. All right, so that's